Good morning, our Caribbean family. My name is Emily Martijn, and I will be your moderator today. On behalf of Lab Knowledge Foundation, I would like to extend you a very warm welcome to our 4th edition of the Caribbean Antimicrobial Stewardship Program virtual conference. We thank you all to taking time off your busy schedule to join us this webinar. We have participants from all the Caribbean. Today in our webinar, we have participants from Suriname, Trinidad and Tobago, Aruba, Bonaire, Jamaica, Guyana, St. Lucia, Grenada, Barbados, St. Kitts, Bonaire, Chile, and Curacao. I'm presenting you from Curacao, our 4th edition of Caribbean Antimicrobial Stewardship Program. Before we start, I want to introduce to you our Director of Lab Knowledge Foundation. I will like to invite Ms. Neila Diaz to give us a warm introduction words.
Good morning. Welcome, friends, colleagues, guests, and fellow healthcare professionals to the 4th Caribbean Antimicrobial Stewardship Conference 2021. It is truly our pleasure to greet all of you today, and I thank you for taking the time to participate in today's webinar. We have an exciting lineup of speakers, and I encourage you to actively engage in sharing your questions as well as your experiences on the topic of this year, the impact of data automation on antimicrobial stewardship. The laboratory has a crucial role in the antimicrobial stewardship efforts as it generates, among others, diagnostic information on what bug is making our patients ill and what antibiotics are more likely to give a positive clinical outcome. However, this diagnostic data only becomes actionable information once it reaches those stakeholders responsible for clinical decision-making. A validated patient result that is not distributed and is only known to the laboratory staff is as good for the patient as having no information at all. The laboratory and physicians are not the only stakeholders in the fight against antimicrobial resistance. The COVID-19 pandemic has clearly shown that active surveillance, epidemiology, and policy, reaching far beyond the walls of healthcare institutions, are all based on diagnostic information generated by laboratories. It is in this same fashion that antimicrobial resistance is measured and monitored using data points generated in the laboratory. It is indispensable then that laboratories throughout the Caribbean develop the capability to detect microorganisms as well as antimicrobial resistance reliably, accurately, and quickly in human, veterinary, and environmental samples. In addition to this, it becomes essential that laboratories and the broader healthcare organizations in which they operate develop the ability to turn diagnostic data into actionable information by shortening the time between validating a patient result in the laboratory and making this result available to physicians. The automation required for this step will also benefit other stakeholders, such as the infection prevention and control committees, central epidemiology and surveillance units, policymakers, and financial and administrative managers. Having said this, particularly in the age where we are constantly bombarded with large volumes of data, it is important to realize that information is not simply significant because it exists. It only becomes important if it is also relevant. The challenge then is in the management of the information to get the right information to the right person in the right format at the right time. Fortunately, data automation presents a great opportunity to manage information flows efficiently and effectively, and therefore becomes a powerful weapon in the fight against antimicrobial resistance. In 2018, we celebrated the first CASP conference in Curacao, where we focused on identifying the stakeholders involved in the antimicrobial stewardship efforts. In 2019, we partnered with the Infection Prevention and Control Team in Barbados to host the second CASP conference, centered around highlighting experiences from the different islands in bringing antimicrobial stewardship policies to life in their institutions. Last year, we celebrated the third CASP conference as a virtual event with the aim of taking a closer look to the different traditional and novel laboratory tests available in the fight against antimicrobial resistance. This year, as we celebrate our fourth CASP conference, throughout this virtual webinar, we focus on data automation as a solution to fast-track clinical decision-making, save lives, and support antimicrobial stewardship efforts on a broader scale and for all stakeholders involved. On behalf of PharmImpacts and Lab Knowledge, I thank you once again for your participation today. We appreciate very much your commitment to building healthy communities and your contribution to creating a world in which increasing antimicrobial susceptibility is our new normal. Thank you very much.
Thank you, Ms. Naila Diaz. Welcome back to our webinar of today. I would like to remember you that you can type your questions in the chat box on the right hand of your screen. After the presentation, we will have some Q&A and a panel discussion. In that part, I will ask then the lecturer your question on your behalf. This week, we are celebrating the World Antibiotic Awareness Week. In 2015, WHO endorsed a global action plan to tackle the growing problem of resistance to antibiotics. One of the key objectives of this plan is to improve awareness and understanding of antimicrobial resistance through education and training. And this is exactly the goal of Lab Knowledge Foundation through these types of webinars we organize. In this slide, we are presenting you today the topic of our webinar, the impact of data automation and antimicrobial stewardship. It is my pleasure to introduce to you our friend of the Caribbean, Dr. Jacques Boncy from Haiti. Dr. Jacques Boncy, Director of National Public Health Laboratory at different institutions in Haiti. Dr. Boncy has more than 30 years of work experience as a head of laboratory. After obtaining his master's degree at the State University of Haiti, Dr. Boncy was trained in tropical medicine at the Institute of Tropical Medicine and Hygiene at the University of Bordeaux, France. He also specialized in hematology at the Saint Antoine Hospital at Paris University, France, microbiology and parasitology at the University of Illinois Medical Center, Chicago, United States, microbiology at the Strong Memorial Hospital, Rochester, in the United States, and microbiology, the National Institute of Health at Bethesda in the States. As the director of the National Public Health Laboratory for the Ministry of Public Health and Population, Dr. Boncy has presided over the establishment of the National Laboratory Network and directed several programs to strengthen the laboratory system. He also served as a professor at the Laboratories of Science and Microbiology. Dr. Boncy collaborates as well for research programs on communicable diseases with the United States Centers for Disease Control, PAHO, WHO, and the Milieu Foundation. Last but not least, Dr. Boncy is the author and co-author on numerous scientific articles on the diagnosis and control of communicable diseases and the implementation of laboratory systems in resources-limited countries. Help me to give a warm welcome to Dr. Jacques Boncy in Haiti. He is presenting us his presentation for today from Haiti. Welcome, Dr. Boncy. The virtual floor is yours.
Thank you very much, Emily. I'm very glad to be able to participate in this Caribbean conference. As you know, Haiti is a member of CARICOM, and it's always a really great pleasure to interact with our Caribbean colleagues and friends. Today, I will talk to you about the implementation of a high-tech automated antimicrobial identification technology in Haiti. This is important to consider that Haiti is a country with a lot of problems, but in spite of a very serious situation affecting the country, it is interesting to note that acquiring high technology and using it for the better of the health system is possible. Next slide, please. Okay, so I am talking to you from the National Public Health Laboratory, and the National Public Health Laboratory, together with the Division of Epidemiology, are located in the same campus at the capital of Haiti, and they are both an institution of the Ministry of Health. Now, the Directorate of Epidemiology, Laboratory and Research is in charge of operating the national surveillance system. It is in charge of planning and organizing the epidemiological surveillance of priority disease, ensure the development and dissemination of tools for collecting health statistics around the country. It's also in charge of processing, analysis, and dissemination of health statistics that will serve for decision-making at the highest level of the ministry. It also established norms and standards for collecting the data and also analyzing this data. The Division of Epidemiology, Laboratory and Research has also as a task to strengthen the capacity of departmental structures. The National Public Health Laboratory is an institution that is part of this compound, and it is a service of excellence reference in the diagnosis and investigation of diseases under epidemiological surveillance. It is equipped with state-of-the-art infrastructures and technology and managed by highly qualified managerial and technical staff. The National Lab established a normative, technical, informative, technological, innovation, and quality training laboratory platform to strengthen the country's response capacity in the context of disease under epidemiological surveillance. Here we consider the National Lab as a strategic unit capable of generating laboratory data that will complement the data collected by the Division of Epidemiology. It is a multi-disease diagnosis center, actually. It is important also to note that the National Laboratory is coordinating a national lab network and operates also a national specimen transport system so that specimens that are collected in various centers around the country can be picked up and brought to the central level to be analyzed. Now, the laboratory, actually the National Reference Laboratory has many reference centers of all laboratories inside the structure. It's not just one lab, but it's actually many labs. So the national reference laboratories, such as the tuberculosis reference laboratory, for example, and the national reference centers, such as the national influenza centers, are located inside the National Public Health Laboratory. And they have a triple mission: service, delivery, research, and expertise. They analyze the samples sent by the peripheral laboratories and consolidate and list key information at the national level. They characterize strain, they tally number of cases, they note trends in disease, and they collect microbiological data aimed to prevent and fight against emerging disease. The surveillance laboratories also play a role in the international level, since the national data collected is then transmitted to networks such as the CARPHA, Caribbean Public Health Agency, the World Health Organization, or the Pan American Organization, PAHO, and also the CDC, Center for Disease Control and Prevention of the USA. These organizations use the data collected by the National Reference Lab and centers to map the situation in Haiti, in the American region, and around the world, and also measure the evolution of risk and monitor the spread on a larger scale. As an example, we can see, for example, that the National Influenza Center was able to conduct surveillance for COVID-19. The test was rapidly introduced, and also all the data collected enable us to actually follow the trends of the epidemic, not only in Haiti, but also to monitor variants of the virus. There are several programs that are conducted at the National Laboratory. One of them is a PRESS-AP program. The PRESS-AP program main objective is to strengthen the national syndromic surveillance through improved laboratory sentinel surveillance for priority disease. These are 15 sites that collect data and also laboratory specimens at the same time. The specific objective of this program is to determine the major etiologies of acute diarrheal disease, acute febrile disease, severe acute respiratory infection, and invasive bacterial disease. Now, as an example here, you have the work that has been done for cholera. There was a cholera outbreak in Haiti. And as you can see, during the several epidemiological weeks, the number of positive cases were fluctuating, and the number of positive, actually the rate of positivity was also fluctuating. After several local intervention, the number of cases drastically diminished from the first epidemiological week of 2019. We didn't have any other positive cases. As you can see in that picture, the cholera outbreak has been under control. Now, our next step is to monitor all cases of acute watery diarrhea to make sure that there is no reemergence of cholera in the country. And this can be done only by culturing all the cases of acute watery diarrhea. It is very important to have a tool to be able to do as much culture as we can and also have a rapid diagnosis. Now, we decided from the funding that was allocated for cholera to actually acquire a new platform, or actually not only a new platform for diagnosis, but a new platform for for drug susceptibility. So there was a committee for selection. The committee for selection has to establish a cahier de charge, and then this cahier de charge was used to conduct the ordering process. The ordering process was also established as a bidding process, and we took precaution to also include a service contract for maintenance. This is extremely important. We think that when you buy a technology like this, you have a long maintenance contract to ensure the efficacy of the product. A pre-installation checklist was elaborated and sent to us. And after we filled that checklist, there was a pre-installation visit by Biomilieu, and 2 engineers for Biomilieu came to the country to actually do an inspection, and they verified everything, including electricity, the LIS, and other environmental conditions. Once we had met everything that was on the checklist, then we were able to proceed to the next step, which was the acquisition of the equipment. Now, the training component was also prepared. There was a selection of users. There was a group organized by Farm Impacts that came along in the country. They conducted didactic training for about 2 weeks, and after that, hands-on training with the technician. There was increased communication with the technical staff and IT staff, and also the LIS manager. Troubleshooting was also addressed, and reagents list identification was also performed. And we also work with Farm Impacts on reagents and supplied procurement system. Now, what are the benefits for us of acquiring Viatec MS and Viatec 2? We can see that there are 4 really good reasons. The first is the speed of identification. The second is the increase in microorganism detection capability. The third is the ease of performance and manipulation. And the fourth is specificity and sensitivity. The speed of identification. The workflow. We are able to detect before the implementation of this new technology, no less than 72 hours was needed to get the positive blood culture growth results. Since the implementation results are available in 48-hour maximum and soon 24 hours, since we are ongoing the validation of the in the laboratory of the method for identifying and testing microorganisms from the positive blood culture growth. For enteric pathogens, before the implementation, the laboratory could only identify Vibrio cholerae species of Salmonella and Shigella in at least 48 hours. With the use of this device, we are able to identify other enteric pathogens within 24 hours. Bacterial meningitis. Currently, all the colonies present on the culture media can be identified within a few minutes, whereas previously it took 24 to 48 hours. We have an outbreak of diphtheria in Haiti. For diphtheria, our method of identification was AP coordinate, which requires approximately 24 hours to get results. With now, thanks to Viatec MS, the strains is identified immediately. What about microorganism detection capability? Before the implementation, the lab had the capacity to identify a very limited number of bacteria due to the reagents procurement needs and workflow. Now, this technology has not only dramatically increased the ability to detect bacteria, but also yeast. Mycobacteria identification is possible, and Vitek 2 greatly facilitated our task by using it to perform rapid sensitivity profile in support of AMR surveillance. Ease of performance and manipulation. Both platforms are very easy to operate. Initially, the technicians complained a bit about the repeated failures they experienced in the preparation of samples for the Vitek MS, but now they are calling for an increase in the menu of tests for microbiological research, giving our ability to identify more organisms. In short, practice makes perfect, and they are very happy about this new technology. About specificity and sensitivity. Before the implementation, in a mixed culture, the technician would select a single colony, rarely 2 colonies, but with this technology, they will select 6 and even more colonies, showing characteristics of a suspected bacteria. This will increase the probability to identify a targeted pathogen if it is present on the culture plate. For antimicrobial resistance, high priority organisms are responsible for outbreaks. These are very important. This is a list of pathogens that we have the responsibility to track, especially Acinetobacter baumannii, Pseudomonas aeruginosa carbapenem resistance, Enterobacteriaceae carbapenem resistance, Enterococcus faecium vancomycin resistance, Staphylococcus aureus methicillin resistance, Helicobacter pylori clarithromycin resistance, Salmonella fluoroquinolone resistance, and Neisseria gonorrhoeae. So with this system, we'll be able to track rapidly those pathogens on the list. Next step, with this new technology, we will be able to identify pathogens directly from growth in blood culture. To conduct identification of non-tuberculous mycobacteria. Since we have a BSL-3 lab dedicated to MTB diagnosis, we have also noted that many isolates are non-tuberculous mycobacteria, and sometimes those non-tuberculous mycobacteria have a clinical expression with severe cases sometimes. So by using the system also for mycobacteria will be one of our objectives. We also will have the capacity to identify new bacterial pathogens circulating in the regions that show specific spectral pattern. Maybe those patterns are not present in the database, but we will share these spectra with biomarkers so we can increase the capacity of detection, since some pathogens may be circulating in the regions and not present in the database. We will be able to support peripheral labs by shipping isolates from these labs to LNSP using the National Transport System. We also be able to identify mold and yeast and also increase the characterization of pathogens by combining proteomics and genomics. This will be done by sending isolates to all reference centers. So, in conclusion, even in very difficult conditions, it is very possible to introduce these new technologies, and these new technologies can serve to strengthen the national surveillance system. I want to thank our Bacti team, Emmanuel Rossignol, Valusnor Compare, and the Bacti IT staff. Thank you very much.
Thank you, Doctor. Indeed, a very nice presentation titled The Advances of Implementation of a High-Tech Automated Antimicrobial Identification Technology in Haiti. I don't know if there are very quick questions that we can handle now. Otherwise, we will continue with our program. We have put together a very nice program, and our next speaker for this morning is Mr. Rajeev Nagassar from Trinidad. He will bring us the presentation with title, The Phenotypic Resistance Patterns of E. coli, Klebsiella pneumoniae, Staphylococcus Aereus, and the links to Stewardship and IPC. Dr. Nagassar is a medical doctor specialized in medical microbiology from the University of the West Indies, St. Augustine, and the Mona campuses. He has a postgraduate diploma in emergency medicine and has received management training at the Arthur Lockjack Global School of Business in Trinidad and Tobago. He is a specialist medical officer and head of Department of Microbiology at the Eastern Regional Health Authority, Trinidad and Tobago. He has worked at that institute. He has also worked as a medical director at the Sangre Grande Hospital of the Eastern Regional Health Authority. He is a part-time lecturer at the University of the West Indies Faculty of Medical Sciences at St. Augustine, a part-time lecturer in microbiology at the College of Science, Technology, and Applied Arts, Trinidad and Tobago. He has served on many Ministry of Health committees and working groups in Trinidad and Tobago. He is the national focal point for several projects, including a collaboration with international partners such as PAHO, WHO. He also currently works with academic colleagues on research into various aspects of medical microbiology. He is working on building national capacity in AMR surveillance and testing. He's a member of National Coordinating Committee to combat AMR. He has also used his training to improve microbiology, antimicrobial stewardship, and infection prevention and control. Even though his main expertise is in antimicrobial resistance, he is trained in mycology, virology, parasitology, and prion diseases. Dr. Rajeev Nagassar has improved neonatal outcomes related to infections in Trinidad and Tobago and contributed to the enrollment of Trinidad and Tobago in WHO Global Antimicrobial Resistance and Use Surveillance System. Help me welcome Dr. Rajeev to present us today his presentation in phenotypic resistant patterns of E. coli, Klebsiella pneumoniae, Staphylococcus aureus, and links to stewardship and IPC. The floor is yours, Dr. Rajeev.
Good morning. Just confirming that you all can see the screen.
Yes, we can.
Okay, so today I'll be speaking to you about phenotypic resistance patterns with regards to specific gram-negative bacteria such as E. coli and Klebsiella, and gram-positive bacteria such as Staphylococcus. I concentrate on E. coli and Klebsiella because in international efforts, they are two of the pathogens that have most concentration in terms of gram-negative organisms, and Staphylococcus aureus, not only that is topical, but it's also one of the organisms that's concentrated on as well. I'd also like to bring out in this I'd like to also bring out in this presentation the link of the lab to particularly stewardship, because as this is a stewardship conference, but we could also look at links to infection prevention and control and surveillance. Right, so as a background, we're going to look at the how did we get here to this study, the methods of the study, results, discussions, and the applications, right? So just moving along. Sorry about that. My slides sometimes stick. Right. So just quick declarations. This work was previously presented. Some of this work is under review for publication, and there are no conflicts. Right. Antibiotic stewardship. So what is the role of the laboratory? Right. The laboratory, we saw in the videos before, right? The laboratory provides validated data for decision making. We provide antibiograms, right? We also provide epidemiological antibiograms, and this study will show how we collect and present some of that data. So this is a study that was previously published. On a background, the World Health Organization has developed a global priority pathogen list of antibiotic-resistant bacteria, right? And also the CDC has a priority pathogen list similar to this, right? What this paper looks at is priority 1 pathogens, such as Enterobacteriaceae, such as Klebsiella, Pneumoniae, and E. coli, including phenotypic carbapenem resistance and mainly third-generation cephalosporin resistant organisms, right? Priority 2 pathogens, according to the WHO priority pathogen list, include MRSA or methicillin-resistant Staphylococcus aureus, which is one of the organisms in this study, right? Globally, there's a high prevalence of MRSA, being as high as 25% in some countries, and globally it is noted also that E. coli and Klebsiella produce ESBLs, and they even produce carbapenem resistance. Actually, KPC or Klebsiella pneumoniae carbapenemase is a well-known carbapenemase that circulates. All right, what did this paper focus on? What this study, it looked at resistance in Staphylococcus aureus, looking at cefoxitin as a gold standard. It focused on ESBL detection, carbapenem resistance, and other resistance to last-line antibiotics and regular antibiotics. And we also looked at fluoroquinolone resistance in the Caribbean subregion. Right, so this study was mainly done at the Caribbean Public Health Agency laboratory, and I was lucky to be part of this study. As I said, part of the study is under review, so I don't want to reveal everything about it. What we did is we sent out a specific call for isolates, and as a result, labs would have sent in data based on this call, right? And we should note that pool data was utilized for regional reporting and not just individual results or data, right? The controls we used are shown here. These are the Vitek controls, as well as ATCC controls, and the data analysis was done using mainly Excel software, right? An ethical permission was sought. However, it was noted that ethical permission was not necessarily needed, and an ethical exemption could be gained because we did not deal with any patient-specific information, and there were no major issues of privacy to any patient, but mainly just confidentiality of data. Right. So the results, we obtained approximately 284 Klebsiella pneumoniae in one data set, 279 E. coli in one data set, and 317 Staphylococcus aureus. So it was quite a number of specimens obtained from different CAFA member states. At least half the CAFA member states submitted data. Cefoxitin resistance ranged, but it was pretty high, and there was also clindamycin resistance, and I would like to show it in a graph really, right? So if we look at this graph, if we look on the right, we see inducible clindamycin resistance. So what this really is when we looking at clindamycin as a method for treatment, we have to do something called a D-test if we're using manual methods, right? Because we could utilize the clindamycin, but it could fail. But how we could check this in the lab? We need to test it next to erythromycin in the lab and do something called a D-test. But automated methods like Vitek and so on, they test it within a well or within a tube, right? And we can see the resistance is pretty high to clindamycin, right? The inducible clindamycin resistance, sorry, right? It's reasonable, right? And also there's oxacillin resistance, right? So this slide gives a better depiction of the clindamycin resistance in Staphylococcus aureus, and it gives the resistance in MRSA versus susceptible Staphylococcus. So the red bars would be MRSA and the blue bars would be susceptible Staphylococcus aureus, right? And if we look at the clindamycin on the left, we would see the high level of clindamycin resistance, which I was trying to point out, right? In addition, if we look more to the right, we will see cefoxitin resistance as a marker of MRSA. So cefoxitin tells us, okay, there's MRSA, and this is done within the systems. When I say system, I mean like an automated system, right, a manual system, and so on, right? And this shows that the cefoxitin resistance was pretty high, right? Noting that in this graph, right, we want to make sure that we clear that this is presented as susceptibilities, right? So the susceptibility to cefoxitin was only about 60%, right? So that means there was at least 40-something% resistance, right? This is now for Klebsiella pneumoniae. And again, I want to get to the graph because the graph will really show you the information, right? For Klebsiella pneumoniae, again, the information is presented as susceptibilities, right, in the graph, right? And again, this shows ESBL producing Klebsiella pneumoniae, which are in red, and susceptibilities of sensitive Klebsiella pneumoniae, which are presented in blue. If we look at the general trend in this graph, we could see the Klebsiellas that are generally not ESBL producers are very sensitive, whereas the ESBL producers, they are not just resistant to the beta lactams, because ESBLs has more to do with beta lactams. They're also resistant to other classes of antibiotics. So these ESBL producers in their genetic material seem to have resistance to other classes of antibiotics, which is why they are important clinically. Right, the susceptible one, as I said, it's more susceptible to other classes, whereas the resistant ESBL producers are not just resistant to beta lactams, they're also resistant to other classes. Because if we know ESBL stands for extended spectrum beta lactamase producers, right? And remember, it says in there beta lactamase. So these would be drugs that have beta lactam rings in them. Right, again, now we move on to E. coli. This shows resistance, but what I like to point out to you, the graphs that I've been showing you, right, the blue and red graphs shows susceptibility, right? Again, the red shows ESBL producers and the blue shows non-ESBL producers or more susceptible E. coli. Now, what we would note is the same pattern, that the ESBL producers have more resistance than the susceptible E. coli. But important to note is that both in Klebsiella and E. coli, even with ESBL producers, we're still able to use last-line drugs like meropenem, tigecycline, right? And these are the last-line drugs. We're able to use some other drugs as well, as we would see in these slides. But what I'd like to point out to you is important to identify the organisms, because if we just look back we see the Klebsiella resistance is actually greater than the E. coli resistance, right? If we look closely. And not only that the Klebsiella resistance is greater, we actually found that there were carbapenem producers in a few member states. It was widely spread, so more studies need to be done because, of course, the methodology of this study wasn't it wasn't a random sample. It wasn't as rigorous in terms of the sampling method. It was more convenient sampling, so we can't really generalize, but we have an idea that there's a resistance problem, including carbapenem resistance. Right. So moving on, it's important for you to understand that you need to identify your bacteria. You need to know if it's gram positive. You need to know if it's gram negative. You need to know if it's an ESBL producer, if it's an MRSA. And then the identity of the organism could tell you if it is more resistant. For example, E. coli is maybe more sensitive than Klebsiella pneumoniae. Right? We saw in this study that cefazolin was a better predictor of susceptibility to cefpodoxime, right? And that there were some errors with cefuroxime, right? Penicillin resistance was seen in Staphylococcus aureus, but this is expected, so I'm not going to go into that. We expect that. Oxacillin and cefoxitin are phenotypic markers of resistance to Staphylococcus aureus, but cefoxitin is obviously the better method if we're using CLSI standards, and those were mentioned in the videos. And importantly, there was no resistance to vancomycin and linezolid, right? And that is important because even if we have MRSA or resistant bug, we could still use vancomycin or linezolid. And there was really no VRE detected there was no VRE detected, which is vancomycin resistant enterococcus. And there was also no VISA or vancomycin intermediate Staphylococcus, which has a little resistance, and no vancomycin resistant Staphylococcus aureus. We know the resistance to vancomycin in staph is not stable. You don't see it a lot, even though you see it sometimes. And VISA resistance is different to VRSA resistance, right? So we noted that last line drugs could still be used and aligned to our objective. Staphylococcus fluoroquinolone resistance does occur, right? Being as much as 20% in some of the in the study, right? Because we can't generalize this to any country, right? And the pattern of resistance is specific to E. coli and Klebsiella because this is what we study, right? And of course, Staphylococcus aureus, right? There was low-level resistance to meropenem and other carbapenems, but there were 4 isolates which were found on further examination to be carbapenem producers, and this is published in a study by Hines et al. So you can look up that paper, Hines et al. Right, again from the same Caribbean-wide study, and this also speaks more to stewardship. Right, E. coli, however, did not show that resistance patterns with carbapenems, and which is why I say you need to know your identity as well, right? Because sometimes your identity could tell you the resistance pattern. An example of that is if you have Streptococcus group A, right? We know all group A Streptococcus in the world are sensitive to penicillins, and the only reason you wouldn't use that is, or the penicillins, the only reason you wouldn't use it is if the person is allergic, right? So limitations of this study, a great deal of effort was needed to obtain the isolates from country laboratories. Communication directly to technology staff succeeded. So sometimes, you couldn't go through, you had to go through calls and so on, maybe emails, right? But sometimes they failed, right? CAFA had to pay for some of these transportation and laboratories could not afford to send it, right? The identification of some discrepancies between our labs and the primary lab or the lab that sent the isolate was labor intensive, right? And impacted on our findings, and thus that those isolates that were sent were not necessarily all that were recorded in the results, right? There was variation in analysis and storage prior to samples being stored, so we couldn't control that, right? We can control what the labs did in their country and what happened in shipment, right? And this is not a true representation of the distribution, but this gives us an idea that there is a problem, right? And that we utilize an automated method, which was the Vitek, and that method proved to be useful, right? And especially in a resource limited setting. But how does all this apply? How does that apply to me? I mean, you telling me about resistance patterns and we talking about stewardship. How does it even matter to me? Because the microbiology laboratory plays an important role in surveillance, treatment, control, and control of nosocomial infections. But more importantly, the microbiologists and the microbiology laboratory are permanent and active members of the infection control and the antimicrobial stewardship groups. So, there's a link there. Your microbiologist and your lab is part of those committees, right? They're part of the surveillance team, right? Most of the infection control and stewardship programs rely on microbiology results. So you can't get away from that. You need the microbiology lab, you need the equipment, right? And quality assurance is an important issue, and automation assists with that quality assurance process. So this is a little diagram that I put together showing the links. The microbiology is linked to surveillance, infection control, and most importantly, stewardship, because this is a stewardship conference, right? So the lab is the missing link, right? And this again shows you another diagram, and this shows you the link with stewardship and the role of the microbiology laboratory. And the persons doing this, they were more stewardship people, right? And I'm biased because I'm a laboratory specialist. I'm a medical doctor, right, who specialize in medical microbiology. And I would actually put the microbiology laboratory where the infection control team is in the center, right? And what does the lab do? It identifies the pathogens, it determines the susceptibility patterns as we saw in the study, and this surveillance information is used for stewardship interventions, for education and reporting of results for individualized therapy or for developing antibiograms such as epidemiological antibiograms. And these are my references and they would have been shown throughout. And do we have any questions? This is the end. Thank you very much. Over to you. Thank you.
Thank you, Dr. Rajeev Nagassar, for this wonderful presentation. I don't know if there are questions already, but I have one question for you. In your presentation, you said that E. coli resistance is difficult of, sorry, I was paying attention to something else. Sorry. In your presentation, you have stated that you didn't see meropenem resistance for E. coli. In the Caribbean, it's known that that we encounter E. coli for and meropenem resistant for E. coli. What are the cases that you encounter in your study, and if you can elaborate a little bit more about what you stated, that you cannot give the guarantee, or you cannot state for all the samples that was sent, because you encounter some problems with sending information.
So thank you very much for your question, Emily. So as I indicated, yes, methodological primary studies, right?
Yes.
If you don't collect samples in appropriate, not appropriate because it was not an appropriate, just the methodology, right? If it's a convenient sample, you kind of just generalize it because this is we selectively send certain samples over others. And in our lab in Trinidad, we do see resistance, and that would be specific, but we do see resistance as well. Primarily, or probably I see resistance, but not specific or where, and so on. It just can't be generalized because of the lack of methodological guidelines in terms of sample collection. That was only because that's what we could have done, right? But we did find resistance, and we did find campaign resistance in Klebsiella pneumoniae. So, we did find, so it does exist, and I agree with you that it is present, and we did find it. In fact, some of my studies, some of my colleagues who have discussions with studies and these things told me they found actually a lot of resistance Of course, I can share that information, but in terms of public resistance unless actual content.
Okay.
So I hope that answers your question and back to you.
Okay. We also prepare some polls, and I want the participants now to participate in the polls. Dr. Nagassar prepared 2 questions. You are seeing now the polls at your right hand in the chat box. We will give some minutes for our participants to do the polls. Dr. Nagassar, you want to elaborate on the 2 questions in the poll? We are not, we don't hear you. We don't hear you, Dr. Nagassar.
My apologies.
Yes.
Do you hear me now?
Yes.
Thank you very much. Right, so thank you for your question. And what are the benefits of contribution in antimicrobial? So I try to make this interactive. Right? So, is it better stewardship? Is it better ICP? IPC? Is it better surveillance? Is it better patient outcomes? Well, the answer is overall it's better patient outcomes, but it touches on all. So all 4 are relevant, but ultimately you get better patient outcomes and you get better surveillance outcomes, you get information for decision. Right, so let's do the second poll.
Yes.
Right, and if we have more questions, over to you, please.
Okay, we will give the chance to do the second poll now.
Okay, so that was quick.
Very quick.
That's too good.
Yes.
Okay, so the information was received. Let's just say that, right? Y'all received the information. I tried to make it clear that us laboratory professionals, whether we be clinical scientists or medical specialists like myself, we help link these various departments, right? Our role is just as important as anybody else, right? We help link for this parts and what is a facilitator or enabler is the contribution. So, Emily, over to you, and thank you very much for this one.
Okay, we will have now a very short to do questions for both Dr. Boncy and you, Dr. Nagassar. The questions we get till now, because in our program, we have programmed a 10 minutes break, but we can use a couple, since we are on time, to do a couple of questions. I'm not able to see the question, but maybe you can help me with the, just a second.
Hi, Emily.
Yes.
Do you want me to assist you?
Yes, because I'm, okay.
Sure, I can see it.
Now I can see it.
Sure, you go ahead.
Okay. What would are, in your opinion, the next step to improve AMS in your countries? What data do you feel you are lacking, and what would be the difference if you had the information? I don't know who I can give the word.
I can start, Emily.
Okay.
Sure. So the next step to improve antimicrobial stewardship, obviously it has to be commitment from a country, whether it be private or
would stand without that engaging stakeholders and get business interest so that's increasing. I mean, we can talk about what is collective data and as we get business interest to collect for decision making. And I can speak to that because I'm the focal point for GLAS, right? And I'm a substance of data, which I can't really speak about, but I've been involved in that. I would have the clinician for stewardship. In addition, even at laboratories where we have the stewardship, right? In addition, to the second part of the question, you know, you need the commitment and you need persons to form stewardship teams. And that's really commitment again, because you need commitment in the private and public sector to form these stewardship teams. And central to all this, we need to know the importance of the laboratory and the medical doctors and the other staff that will be responsible for stewardship. So over to you. Thank you very much.
Okay. Dr. Jacques Boncy, you want to elaborate
Yes.
on your part?
Yes, thank you very much. We have a strategic plan for antimicrobial resistance in the country. And this strategic plan, we have decided to capacitate several labs to increase the capacity to diagnosis, microbiological diagnosis. We recognize that it's very difficult to actually develop full-scale microbiology capacity in several hospitals at the same time. So we have chosen to link those laboratories with the national lab. They will do certain basic culture, and they will be able to ship isolates to the national lab using the national transport system, where we have higher capacity, and then we will be able to link also their data with our central database, and eventually even LIS with our central LIS. So this will definitely increase our capacity to select or detect emergence of resistance and also emergence of pathogens. It's important also to collect good clinical data, and this is something that we are to work on by developing a good data collection tool that will be standardized and also can be used by all the participants of the network. I think that by doing this, we will improve microbiological structure in the country. We will use less effort and less funding, although by doing this, it will be effective. Thank you.
Okay. Thank you, Dr. Boncy. We have now on program a break of 10 minutes. After the break, we will have presentation of Milenko Fuentes that will present us management information system for microbe lab and epidemiologist system. We will come back with discussion after the presentation of Milenko with a panel discussion. So meanwhile, in the break, if you have questions, I encourage our participants to keep sending your question in the chat box, and then when we get back after the break and after the presentation of Milenko Fuentes, we will do a panel discussion and a Q&A. Thank you. Thank you so far.
Curacao has a hot new vibe and is now the place to be. An explosion of art, architecture, and restaurants has spurred redevelopment, transforming Curacao into one of the hippest destinations in the Caribbean. But the island still radiates its European charm, natural beauty, and wonderful mix of Dutch, Spanish, Caribbean, and African cultures. Visitors must go and feel it for themselves. Located on the outer fringes of the hurricane belt, Curacao is easy to reach by nonstop flights from 6 North American gateways and by same-day service from 40 cities in the USA and Canada. Still a member of the Kingdom of the Netherlands, daily nonstop flights from Amsterdam and many flights arrive from 9 South American and Caribbean locations. English is spoken widely, along with Dutch, Spanish, and Papiamentu, the local language. Curaçao's dry, sunny climate and an average temperature of 87 degrees Fahrenheit make it a mecca for every variety of outdoor activities. Visitors won't have to change money. While the official currency is the Netherlands Antillean Guilder, or NAF, US dollars are widely accepted. And the water is safe to drink, straight from a modern desalination plant. Want to know more? Watch our other videos to learn all the things you need to know for planning personalized dream vacations. You'll see where to stay, lounge, dine, and party. You'll get tips on the hottest areas like the Peter Mai district, the best beaches, where to access shore and ocean dives, and all kinds of land and water-based activities, some that are unique to Curacao. So, welcome to Curacao and its hot new vibe. Visitors must go and feel it for themselves.
Espera por nadie, yo voy a gozarme todos los detalles. Nada de tristeza, solo sonrisa y mucho baile. Vamos de paso por esta vida, así que vive tu día a día. Todo es prestado, todo termina, no tengas prisa. Vamos a romper las barreras, no te ahogues en tus penas, siempre habrá una manera. Ya no vivamos más esta mentira, vamos a salirnos de la misma rutina. Hey, mira, de 9 a 5 se nos va la vida. Cambia tu historia, busca la alegría. Vamos para arriba. Hey, mira, oh. Hey, mira, y nos vamos para adelante, para adelante.
pensar en vivir la vida.
Es tu vida.
Y si piensas que el tiempo se va y te deja, recuerda cuando amanezcas, tus sueños siguen en la mesa. Ay, mira, confía en la magia de tu melodía. La ruta es larga, pero sé que tiene salida.
Vamos a romper las barreras, no te ahogues en tus penas, siempre habrá una manera. Ay, mira, ya no vivamos más esta mentira, vamos a salirnos de la misma rutina. Ay, mira, de 9 a 5 se nos va la vida, cambia tu historia, busca la alegría. Vamos para arriba. Ay, mira,
Siéntela,
ay, mira,
bailala,
ay, mira.
siéntela.
Ya no vivamos en esta mentira. Cambia tu historia, busca alegría. Busca alegría, mi vida. Que nos vamos pa'lante, pa'lante.
Ay, mira, confía en la magia de tu melodía. La ruta es larga, pero sé que tiene salida. Ay, mira, confía en la magia de tu melodía. La ruta es larga, pero sé que tiene salida.
Welcome back, our Caribbean family. I hope you are enjoying our webinar as we have put together a wonderful and nice program. I hope everyone had a refreshing water break and that you took a dip in the crystal waters that connect us as a family. Now, it is my pleasure to present to you our next speaker, Mr. Milenko Fuentes, with the topic, the title of his presentation, Real Clinical Impact. Milenko Fuentes works with our vendor and event sponsor, bioMérieux, manage the IT solution product line. He has been working with bioMérieux for 6 years. He lives in Chile, but will be joining us this morning from the sunny island of Dominican Republic. Mr. Milenko Fuentes, welcome, and the floor is yours.
Thank you. So I just want to say hi, everybody from every country that you are watching me right now. As you perfectly said, I'm from Chile. I worked during the last 6 years from this Chilean subsidiary, but now I'm working with the international division here in bioMérieux. So the main topic from this presentation is talk about the software that we can call as well as a tool. And this tool, of course, is have a... Sorry, I hear some... Okay. So this tool has many benefits, starting these benefits on the laboratory. But of course, it has a clinical impact too, because it's a software that could and you can integrate it and escalate it into the clinical and hospital environment. So let's start with the presentation. I hope you are hearing me well. So let's start with our agenda. Our agenda start with the impact of the correct information management. We are going to talking about some statistics reports, some indicator for blood culture optimization. We're going to talk about a little bit the fast clinical support, how we can create this impact related with the information that we can or could help to a better management for the patient. And the last topic is about some feature that we think is very important to promote, especially with the physicians, and the physician that probably not always is the physicians that are reading reports, microbiological reports. So, and that's an issue that we address in the last few years. And so we managed this to create automatic notes for a better management of the patient. So let's start this presentation with some clinical challenge that maybe you know even better than me. And the first clinical challenge that you have in a hospital environment, of course, is the diagnostic. So I imagine that very many doctors that we have here in the audience have this challenge too, because they need to confirm the diagnosis in the shortest time possible. Okay, that's and from bioMérieux we have some tools that we can use to accomplish that. And the second challenge we could talk about treatment, specifically the empirical treatment. And when we're talking about empirical treatment, of course, we have to address the antibiotic treatment or antimicrobial treatment. And of course, within the environmental environment in the hospital, we have to prevent and control hospital infection, but this prevent and control has to be with epidemiological information. Sorry about that. So let's start with our first topic, the impact of correct information management, how we can address this topic. In real, that is the software that we can use within the laboratory. We have many statistic reports, and this is one of them. And we think that we can use this report known as microorganism frequency. This report, it allows us to know the most frequent microorganism in the institution to optimize the empirical treatment according of the type of patient and site of infection. As you see here in this graphic, we could see an example of this statistic, and we could see, for example, how many Staph aureus we have isolated in some period of time, of course, how many Staphylococcus hominis, and with this, you could know on first hand, for example, in a blood culture, on urine culture, which is the most common organism, and with that, create local guide for empirical antibiotic treatment. And also we have this statistic that put in manifest the community MIC. So this chart is showing us the distribution of and the percentage on every MIC value. For example, sorry, I have some words in Spanish, but I think that you could manage. So for example, if we see in the first column, the antibiotic could be, I don't know, cloxacillin, for example. And if we analyze, for example, the 31% of the Staph aureus isolated in some period of time, 31% of that Staph aureus is in the 0.25 MIC. So with that information, we could detect some trends that allows the establishment of prevention measures to avoid the spread of these emerging resistant strains. So we could, for example, compare one year to another and see if we have some trends to tend to go to the resistant patterns or to the resistant MIC. So with that, I'm evaluating if, for example, my environment or my microorganism environment is trending to the resistant, and take some action before maybe it's going to be too late. We have also the resistant distribution. This chart here have a lot of information, but I want you to focus on the sensitivity percentage. So in this case, we have an example of Klebsiella pneumoniae with the total isolation, the antibiotic, and the percentage of sensitivity, intermediate, and resistant value for every antibiotic. So with this, we could guide clinical decision, as well as the preparation of clinical guidelines, local clinical guidelines for direct treatment, and also for education purposes for MAS program, for example. So with this, we could manage and know my local epidemiology and know, for example, how sensitive are Klebsiella for, I don't know, amikacin, or how many ESBL I have, or how many resistant I have for carbapenemase. So this could help to create this local guide, and this have a great impact on the empirical treatment too. And we have also some indicators based on information, of course, and we could use this indicator related to blood culture or the collection sample from blood culture. For example, know my positivity rate and know the appropriate indication of blood cultures and the correct time that the sample has been recollected. So we could have, for example, the total of blood culture taken, how many of those are negative, the percentage of negative, how many positive I have, the percentage of positive. And with this, as I said, we could know if my blood culture, my set of bottle is well taken. I'm taking it when the patient is presenting the right signs and symptoms, and with this, evaluate this procedure. We could know this indicator and adding some filters, for example, for patient location. So we could know for every patient location, for example, ICU or the pediatric ICU, and know how many patients I have positive that has had a positive bottle, the percentage of positive, the total sample, the positive samples, and the percentage of positive samples. And we could also register on the software the volume that was added to the bottle. You know, maybe the volume is one of the key KPIs that we should measure to know if the bottles are filled with the correct volume. And this, as you know, probably has a direct impact on the performance of the blood culture on every patient. And for example, we could extract this list that you are seeing here in this picture, knowing the order date, the barcode of that bottle, the study type, the sample type, the test, and the volume. So, for example, in this image, we could see clearly that probably the volume for every bottle is not the correct volume. As you know that the correct volume of the optimum volume is 10 ml and not 5. So probably we could manage to educate the patient and the clinical services and reinforce that the correct volume is 10 ml, for example. We also, it's very important related to the collection of the sample collection, is the indicator of contamination, and know how many bottles or samples were contaminated within on every month, every week. And with that, optimize the resources performance. And most important, don't miss out on detection of the true infection, because if the sample collection is not properly taken, we are going to, the bottle is going to sound positive, but for example, with Staphylococcus coagulase negative. So this we are missing some resources, and we are missing the true bacteremias. So this indicator could be managed and could be extract like for phlebotomies. For example, we could even go to the specific nurse that are contaminating our bottles and educate every staff that is related to the sample collection. And also we could extract this indicator by patient location and make or create this instance for educate the entire service or clinical service as well. When we have, for example, our instrument or equipment as Bachelor connected to RIA, we could extract this indicator known as time to detection. So with this, we could know how much time takes on a specific microorganism to flag positive on the equipment, and have some measures to the minimum detection time, maximum detection time, for example, the average and the mean detection time. And with that, create, for example, self-validation rules based on your local reality for your hospital or your facilities. So I have a question that maybe you could talk with your team, and it's related with the negative blood culture. Is a negative blood culture clinically relevant? In my personal opinion, I think it's very important because if a blood culture, the majority of the blood culture flags positive before the first 24 hours. So we have some recommendation based on this guide, it's a Spanish guide that said that if no growth is detected after 48 hours of incubation, it is recommended to issue a negative preliminary report, because with that information, the physician could take some action and maybe discharge the possibility of a blood culture or a blood infection, and maybe the fever or maybe some sign and symptom are due to other infection or side of infection, or probably this could help to the physician to find or search other infection in other type of sample, for example. And how real could help on this? We have here on the left side of this slide a bachelor that is always and continuously communicating information to real and real to the physician, and we can manage to send this preliminary report every 12 hours, every 24 hours, every 36 hours until completing the 5 days of incubation. So it's real-time information. It's not depending on a microbiologist working on the lab, because this is a self-validation report, and you can configure this as you wish. Even you can send preliminary report every hour, every 2 hours. So depends on your reality and depends on your needs. Let's continue with the next topic about the fast clinical support and how real can manage and can address this clinical support. First of all, it's very important and how we can provide a tool that allows the physician to search results in an easy way, in a fast way to access these patient results. And this in this image that you are seeing in the left side of on the slide is an example of the option a physician has or a nurse have to search some patient by demographic data, name, surname, ID, sample type, result type as positive or negative, study, I mean urine culture, blood culture, stool culture, and microorganism and patient location. So you have many filters that you can apply, depends on your needs. Also, we have this option for create this dashboard, and with this dashboard we can quickly create this group of relevant results for the institution. For example, we can group in a dashboard positive blood cultures, or every KPC detected in a culture, every ESBL, every vancomycin resistant, and in this way be more efficient when you have to search for some results. It's a very friendly software, and you can create this dashboard as you wish, with the color as you wish and the grouping as you wish. Here we have another example to be more efficient. We're looking for real-time patient result. For example, we have dashboard related to virus sample management, blood culture sample management, urine culture sample management, and film array sample management. Continue with this fast clinical report. We had also an option with you could receive in your email, personal email, or on your email, or institutional email, some relevant clinical information at any time, any hour, 24/7, with information that that you could use for a better management of your patient. For example, you could receive that some patient, a specific patient, has a positive blood culture, and you could receive, for example, the patient location, the date of the order date, or the date when the sample was taken, the time to detection, if we are talking about a blood culture, the gram stain, or for example, we could receive, or you could receive emails with resistant phenotypes. For example, an MRSA has been detected in a blood culture for the patient. This is just an example with the barcode, just an example, and with a note telling you that you could check the real system for more information if you want more information or want to know the rest of the antibiogram results. And you could also receive this kind of information, a complete information for a film array panel, for example. So not always is necessary to receive a specific report and a specific result. You could also receive the entire panel for, as you are seeing here in this film array result, and you could receive this relevant clinical information, and this could help you in quick decision making. And this is, of course, customizable information according to every laboratory, according to every hospital, and according to every physician needs. And our last topic is about the smart reports and how we could help the interpretation of complex results, especially when, for example, we have a physician, maybe it's not the specialist or the infectologist physician. So we have to think about that every person that is reading that report of result could know and could interpret the best way possible the results, especially with results that are complex as antibiogram or complex result as film array panel, for example. So we create this easy to read result report for clinicians, and we create these automatic comments in the final report. And this automatic comment could be configured with clinical or epidemiological consideration. For example, as you see in this image, this is just an example that we detected adenovirus, and we detected SARS COVID-19, and automatically a comment was added, giving some clinical consideration. For example, adenovirus has been detected, contact precautions should be taken for the patient, or SARS-CoV-2 has been detected, please record the positive result in your national surveillance system for contact traceability, for example. So you could add these comments, these footnotes on every report, for example, regarding results on the ID from a specific microorganism, for example, Enterobacter cloacae, where the comment is Enterobacter cloacae has been identified. This suggested not to treat with third-generation cephalosporins. Or in the case of film array, we could add some comment regarding the resistant mechanism detected, in this case KPC. So it is suggested not to treat with carbapenem, cephalosporin, or aztreonam. And this note and these footnotes or comment could be for every high medical value test, film array, virus, Vitec, and in this case we could add this comment in which we are helping to the physician or making a little recall for the physician that he should check the patient age, and in the case for the dimer, they had to evaluate the age of the patient, because if the patient is older than 50 years, you must multiply this result by 10 and to have the final result. Okay. And it's very important when you are creating this comment, this automatic comment. Of course, this comment must be authorized and validated by the institution before the use, of course. And this validation or authorization must be created by the MAS committee, the pharmacologists, the infectologists, microbiologists, and even the laboratory, and as a team create this note and use this note and the report that you think would be more beneficial for every patient and more beneficial for every clinical service or physician as well. So here are some final messages for you, and these messages are divided in three different areas, as you can see. The first area is the laboratory. So REAL promotes and enhances the improvement of processes to optimize the response time or time to result towards the decision maker. As you know, this could be the physician. Consolidate the role of the laboratory within the institution as innovation leader and promoter of high medical value solution that impacts on the patient management. Many times the laboratory are seen as an innovation department. So with REAL and the benefit that REAL has, the main idea is and the medical director start to understand that the laboratory could be a center of innovation too. It allows to establish a long-term project with the global proposal, our global proposal in bioMérieux. In the physician side, enables the quick communication to clinical service, because generates information that impacts on the patient management and outcome. And of course, we could reduce the length of stay for every patient and the antibiotic use for the entire institution. And regarding the committee or the committee that prevents a hospital infection, comprehensively manage outbreak surveillance and the monitoring of antimicrobial resistance, and also allow the clinical intervention according to the type of patient, considering not only the microbiological context, but also the clinical context that and create this mix of information, considering the laboratory information and the clinical information, and with that had a better outcome for the patient. So that's it. I don't know if anyone have a question, something. Yeah, I can hear something right now. I don't know if.
There is one question.
Thank you, Mr. Milenko Fuentes.
Oh, thank you.
Yes, we will, please stay connected because we will discuss questions that are coming up from our participants with you. But I want to move on to the next part of the program, that is the panel discussion, and we will include also the questions coming up in this part of the program. To start this panel discussion, I want to introduce to you Mr. Giancarlo Zimmerman. He has his bachelor degree in medical microbiology. He has 12 years of experience as a medical technologist in a microbial lab working in the Caribbean and in the Netherlands. He had always particular interest in AMR and Caribbean Antimicrobial Stewardship programs. He is based now in the Netherlands, where he works and in a hospital, and is planning to start his master's degree in molecular life sciences. Welcome, Mr. Giancarlo Zimmerman, to do with us this panel discussion.
Good morning, good afternoon. I'm happy to be here with you all today.
Yes, Giancarlo is with vacation in our beautiful island, Curacao. So I asked him, please join us. Seeing his interest in this topic, join us today to discuss with you all the questions we will have in this part of the program. First, Giancarlo, I want to ask you a couple of questions, and I will relate it also to the speakers. Giancarlo, with your work experience both in the Caribbean and in the Netherlands, do you recognize the resistant pattern of the Caribbean as described by Dr. Nagassar in his presentation?
Yeah, I do recognize it, not only in the presentation of Nagassar, but in the other one, the first one too. I saw we have similar, it's not a big difference. It's still the same in the Netherlands or here. I think there's no big difference in resistance now in this world or somewhere else. So for me, both of them are the same I saw.
Okay.
And the only difference was that in how do you call it? In the second presentation of Nagassar, but I think you asked him already. He didn't have he didn't see a meropenem E. coli resistant. So maybe I think there was not enough information maybe he get. But I think in the Caribbean we have, but I think that there was not enough information yet for him to do his study. Am I correct or not?
Dr. Nagassar, you want to?
Yes, I agree. And remember, I indicated in the response that I have colleagues who are doing research into those things, and I can't speak about their research, but what I know is some of them have not just seen carbapenemases, but resistance such as porin mutations and so on. And you see them phenotypically. Yeah? When you look at the antibiograms, you would see like pump and porin phenotypes, like imipenem sensitivity, meropenem resistance, or meropenem resistance, imipenem sensitivity. So you do see it, right? So it's a valid comment, and I agree with you.
My second question I want to ask the whole platform here is also in a presentation of Dr. Nagassar. He mentioned a very low resistance to vancomycin in the Caribbean. However, Dr. Boncy mentioned having found Enterococcus faecium vancomycin resistant in Haiti. Can you both elaborate a little bit more about your findings, different findings? And Milenko, if you want to add also to the discussion, you are welcome. I don't know who I can give the word first. I think Dr. Boncy, since it is found in Haiti. Dr. Boncy, you hearing me? No?
Would you like me to start?
Yes, please.
Okay,
yes,
hi, good afternoon, and thank you for the question. So just to clarify, you're asking about the lack of resistance, the no resistance seen in our Caribbean wild study, with some resistance seen in Haiti, right? Hello?
Percentage on
Hello? Are you
zero
hearing me?
percentage.
Okay,
Yes,
so
I hear you.
I understand what you're trying to ask, right? So remember I told you the methodological rigor, wasn't that it was lacking. It's based on our reality. We were unable to get
Okay.
random samples. Also, only half of the member states sent samples, not all, right? So and this was based on a call, so they sent voluntarily, so that also biased the process, right? And I could tell you, right, it's not that you don't see vancomycin resistance, and there's a study that's been done on enterococci where they do see some vancomycin resistance, right? But we know the resistance in staphylococci to vancomycin. It's mostly you would see the intermediate type, but you wouldn't see clear resistance because we know from the science that it's an unstable mutation that causes the resistance. So generally, it's not common, but you will see it, and you would see it in enterococci more than staphylococci. Over. And of course, due to the
Okay.
methodological,
Shankar,
it's used. So, over to you.
thank you. Giancarlo, with your experience in the Caribbean, did you see vancomycin resistance in the labs you have been working?
I think in my 12-year experience in Holland and in Curacao, I saw it like one time, just one time. It's not like MRSA that you find every week or every month, but it's not so much. But still, I wanted to know where or how they get it in Haiti, because that's relevant for us, where they found it and how they found it, where it come from. So if it's from food or from a patient with another patient, that's the question I have for them. But I think the one is not answering now.
Let's try Dr. Boncy. You hearing us? No? I think Dr. Boncy is still connected, but we cannot hear him for the answer. Milenko, do you have any? Milenko, I just asked you if you want to add to this discussion. We are not hearing.
So hello, can you hear me?
Yes? Yes, we can hear you.
Yeah, no, because I lose connection for the last minute, so I didn't hear the what you were talking about. Sorry.
No, we were discussing the presence of vancomycin resistant in Caribbean and also in the Netherlands. So I ask you if you have anything to add to the discussion. Otherwise, we will move to the.
Okay, no, for the moment.
Otherwise, we will. Okay.